Chapter 31: Critical Care of Patients with Shock. The priority concepts for this chapter are perfusion and infection. The interrelated concepts for this chapter are clotting, gas exchange, and immunity. Any problem that impairs perfusion and gas exchange to tissues and organs can start with the syndrome of shock and lead to life-threatening emergencies. Shock is often a result of cardiovascular problems. Patients in acute care settings are at high risk, but shock can occur in any setting. For example, older patients in long-term care settings are at risk for sepsis and sepsis shock related to urinary tract infections and pneumonia. When the body's adaptive adjustments or compensation or health care interventions are ineffective or exhausted and shock progresses, it can lead to cell loss, multiple organ dysfunction syndrome, and death. Organs, tissues, and cells need a continuous supply of oxygen to function properly. The lungs bring oxygen into the body through ventilation and gas exchange, and the cardiovascular system delivers oxygen by perfusion to all tissues and removes cellular waste. Shock is widespread abnormal cellular metabolism that occurs when gas exchange with oxygenation and tissue perfusion needs are not met sufficiently to maintain cellular function. It is a condition rather than a disease, and is the whole body's response that occurs when too little oxygen is delivered to the tissue. All body organs are affected by shock and either work harder to adapt and compensate for reduced gas exchange or perfusion or fail to function because of hypoxia. Shock is a syndrome because the problems resulting from it occur in a predictable sequence. Types of shock vary because shock is a problem caused by a pathologic condition rather than a disease state. More than one type of shock can be present at the same time. For example, trauma caused by a car accident may trigger hemorrhage, leading to hypovolemic shock, and a myocardial infarction, leading to cardiogenic shock. Hypovolemic shock occurs when too little circulating blood volume decreases preload and stroke volume, thereby decreasing MAP, which results in inadequate total body perfusion and gas exchange. Common problems leading to hypovolemic shock are dehydration and poor clotting with hemorrhage, hemorrhagic shock. A discussion of this pathology and management of hypovolemic shock will be covered in this chapter. Cardiogenic shock occurs when the heart muscle is unhealthy and pumping is impaired. Cardiogenic shock is most often associated with acute myocardial infarction. Any type of pump failure decreases cardiac output and the MAP. Distributive shock, also known as vasodilatory or vasogenic shock, occurs when blood volume is not lost from the body but is distributed to the interstitial tissues where it cannot perfuse organs. It can be caused by blood vessel dilation, pooling of blood in venous and capillary beds, and increased capillary leakage. This results in decrease in systemic vascular resistance, venous return, stroke volume, cardiac output, and MAP. Some causes of distributive shock include anaphylaxis, sepsis, adrenal crisis, and spinal cord injury. Anaphylaxis is an extreme type of allergic reaction. It begins within seconds to minutes after exposure to a specific allergen in a susceptible adult. The result is widespread loss of blood vessel tone with decreased blood pressure and cardiac output. Sepsis is a life-threatening organ dysfunction brought on by a dysregulated system response to infection. Septic shock is a subsequent set of sepsis in which circulatory, cellular, and metabolic abnormalities substantially increase the risk of death over that associated with sepsis alone. Septic shock is the most common cause of distributed shock. Obstructive shock is caused by problems that impair the ability of the normal heart to pump effectively. The heart itself remains normal, but conditions outside the heart prevent either adequate filling of the heart or adequate contraction of the healthy heart muscle. One common cause of obstructive shock is cardiac tamponade. Although the cause and signs of initial symptoms associated with the different shocks can vary, eventually the effects of hypertension and anaerobic cellular metabolism result in the key features of shock. Gas exchange and perfusion depend on how much oxygen from arterial blood perfuses the tissue. Perfusion is related to mean arterial pressure. The factors that influence MAP include total body volume, viscosity, cardiac output, heart rate times stroke volume, size and integrity of the vascular bed, especially the capillaries. Total blood volume and cardiac output are directly related to MAP, so increases in either total body blood volume or cardiac output raise MAP. Decreases in either total body blood volume or cardiac output lower the MAP. The size of the vascular bed is inversely or negatively related to MAP. This means that increases in the size of the vascular bed lower MAP and decreased raise MAP. The small arteries and veins connected to capillaries can increase in diameter by relaxing the smooth muscle in vessel walls, vasodilation, or decrease in diameter by contracting the muscles, vasoconstriction. When blood vessels dilate and total blood volume remains the same, blood pressure decreases and the blood flow is slower. When blood vessels constrict and the total body volume remains the same, blood pressure increases, the blood flow is faster. Blood vessels are inverted by the sympathetic nervous system. Some nerves continuously stimulate vascular smooth muscle so that the blood vessels are normally partially constricted, a condition called sympathetic tone. Increases in sympathetic stimulation constrict smooth muscle even more, raising the MAP. Decreases in sympathetic tone relax smooth muscle, dilating blood vessels and lowering the MAP. Perfusion to organs adjusts to changes in tissue organ oxygen needs. The body can selectively increase blood flow to some areas while reducing flow to others. The skin and skeletal muscles can tolerate low levels of oxygen for hours without dying or being damaged. Other organs, like the heart, brain, liver, pancreas, do not tolerate hypoxia, and a few minutes without oxygen results in serious damage and cell death. Happens in stages. The syndrome of shock progresses in 4 stages when the condition that causes shock remains uncorrected and poor cellular oxygenation continues. These stages widely variable and the pattern of progression is unpredictable, but the stages are initial stage, compensatory stage, progressive stage, and refractory stage. The initial stage is where the anaerobic metabolism in some tissues. The initial stage is a decreased tissue perfusion occurs. The cause of the decrease in perfusion is relative to the type of shock. With hypovolemic shock, perfusion decreases because of decreased intravascular volume. With cardiogenic shock, perfusion decreases due to decreased myocardial contractility. An obstruction of blood flow is obstructive shock, and or decreased vascular tone is distributive shock, cause the decrease in perfusion. This decrease in perfusion leads to cellular metabolism impairment, resulting in increased anaerobic metabolism in some tissues with production of lactic acid, although overall metabolism is still aerobic. There is no obvious clinical signs of shock in this stage. During the compensatory stage, we see sympathetic stimulation, vasoconstriction, increased heart rate, decreased pulse pressure, chemical compensation, rapid deep respirations, glucocorticoid and mineralocorticoid release, renin, aldosterone, and antidiuretic hormone secretion, decreased urine output, stimulation of the thirst reflex, some anaerobic metabolism in non-vital organs, mild acidosis, mild hyperkalemia, and hyperglycemia. The compensatory stage of shock occurs when decreased tissue perfusion occurs and triggers neural, endocrine, and chemical compensatory mechanisms to maintain the MAP and supply oxygen to the vital organs. The neural compensation response stimulates the sympathetic system, resulting in systemic vascular constriction, coronary artery dilation, increased heart rate, and increased myocardial contractility. This response is effective, and both the cardiac output and MAP are maintained within the normal range. While perfusion to vital organs, like the brain and heart, is maintained, there is a decrease in perfusion to non-vital organs, the kidneys, the GI tract, the skin. However, it is not great enough to cause permanent damage. This decrease in perfusion to kidneys triggers the release of renin, ADH, and aldosterone to start kidney compensation. Urine output decreases, sodium reabsorption increases, and widespread blood vessel constriction occurs. ADH increases water reabsorption in the kidneys, further reducing urine output, and increases blood vessel constriction to the skin and other less vital tissue areas. Together with actions to compensate for shock by maintaining the fluid volume within the central blood vessels. During this stage, metabolites build up from anaerobic metabolism. Consequently, some patients will have mild acidosis or a low blood pH and mild increase in blood potassium levels. Decreased perfusion to the lungs leads to a ventilation-perfusion imbalance that triggers a chemical compensatory mechanism to increase oxygen supply by increasing rate and depth of respirations. This mechanism can also be triggered if there is mild acidosis. As a patient breathes quickly, carbon dioxide falls and pH increases, alkalosis, which causes vasoconstriction of the cerebral blood vessels. This can lead to cerebral hypoxia and ischemia. Because vital organs function is not disrupted in this stage, the indicators of shock can be difficult to detect. Signs and symptoms of the compensated stage include changes resulting from decreased tissue perfusion. Subjective changes include thirst and anxiety. Objective changes include restlessness, irritability, increased heart rate, increased respiratory rate, decreased urine output, falling systolic blood pressure, rising diastolic blood pressure, narrowing pulse pressure, cool extremities, pallor, ash-gray appearance, and a decrease in oxygen saturation. Comparing these changes with the values and observations obtained earlier is critical to identify this stage of shock. If the patient is stable and compensatory mechanisms are supported by interventions, the patient can remain in this stage for hours without having permanent damage. Stopping the condition that started shock and providing supportive interventions can prevent the shock from progressing. The effects of this stage are reversible when nurses recognize the problem and coordinate the interprofessional healthcare team to start appropriate interventions. The progressive stage of shock occurs when compensatory mechanisms are functioning but can no longer deliver sufficient oxygen, even to vital organs. Vital organs develop hypoxia and less vital organs become anoxic or no oxygen and ischemic, cell dysfunction or death from a lack of oxygen. As a result of poor perfusion and a buildup of metabolites, some tissues die. Indications of the progressive stage include a worsening of changes resulting from decreased tissue perfusion. The patient may express a sense of something bad or an impending doom feeling about to happen. The patient may be confused and thirst increases. Objective changes are a rapid weak pulse, low blood pressure, pallor or cyanosis of the oral mucosa and nail beds, cool and moist skin, anuria, and a decrease in oxygen saturation. Laboratory results may show a low blood pH along with rising lactic acid and potassium levels. Conditions causing shock must be corrected within 1 hour or less of progressive stage onset. This is a life-threatening emergency. The refractory stage of shock occurs when too much cell death and tissue damage results from too little oxygen reaching the tissues. Vital organs are having extensive damage and cannot respond effectively to interventions, and the shock continues. So much damage has occurred with the release of the metabolites and enzymes that damages vital organs continues despite interventions. The sequence of cell damage caused by the massive release of toxin metabolites and enzymes is termed multiple organ dysfunction syndrome, or MODS. Once the damage is started, the sequence becomes a vicious cycle as more dead cells open and release more metabolites. These trigger small clots or microthrombi to form, which blocks tissue perfusion and damages more cells, continuing the devastating cycle. The liver, heart, brain, and kidney functions are lost first. The most profound change is damage to the heart muscle. Signs are a rapid loss of consciousness, non-palpable pulse, cool, dusky extremities, slow, shallow respirations, and unmeasurable oxygen saturation. Therapy, including fluid replacement, is ineffective in saving the patient's life, even if the cause of shock is corrected and the MAP temporarily returns to normal. Hypoxic shock occurs when too little circulating blood volume causes a MAP decrease that prevents total body perfusion and adequate gas exchange. Hypovolemic shock from hemorrhage or hemorrhagic shock is common after trauma or surgery, and internal hemorrhage occurs with blunt trauma, GI ulcers, and poor control of surgical bleeding. Hemorrhage leading to hypovolemia also can be caused by any problem that reduces the level of clotting factors. Hypovolemia from dehydration can be caused by any problem that decreases fluid volume intake or increases fluid volume loss. The overall cause is a total body fluid decrease in all fluid compartments. Specific risk factors again are hemorrhage, trauma, GI ulcers, surgery, inadequate clotting, hemophilia, liver disease, cancer therapies, anticoagulation therapies, dehydration, vomiting, diarrhea, heavy diuresis, diuretic therapy, nasogastric suctioning, and arginine vasopressin deficiency. The exact incidence of hypovolemic shock is not known because it is a response rather than a disease. It is a common complication among hospitalized patients in emergency departments and after surgery or invasive procedures. Recognizing hypovolemic shock is a major nursing responsibility, identifying the patients at risk for dehydration and assessing for early signs and symptoms. This is especially important for those who have reduced cognition or mobility or who have an MPO status. Assess all patients with invasive procedures or trauma for obvious or occult bleeding from impaired clotting. Compare pulse quality and rate with baseline. Compare urine output with fluid intake. This includes monitoring trends in intake and output as well as changes in daily weight. We want to check the vital signs of patients who have persistent thirst. Assess for shock in any patient who develops a change in mental status, an increase in pain, or an increase in anxiety. Want to teach our patients who have invasive procedures about the signs and symptoms of shock. Stress the importance of seeking immediate help for obvious heavy bleeding, persistent thirst, decreased urine output, lightheadedness, or a sense of impending doom. Ask about risk factors related to hypovolemic shock. If the patient is alert, question him or her directly. If the patient is not alert, collect information from family members. Ask about recent illness, trauma, procedures, or chronic health problems that may lead to shock, like gastric ulcer, general surgery, hemophilia, liver disease, any prolonged vomiting or diarrhea. Ask about the use of drugs such as aspirin, other NSAIDs, diuretics, and herbal supplements that may cause changes leading to hypovolemic shock. Ask about fluid intake and output during the previous 24 hours. Information about urine output is especially important because urine output is reduced during the first stages of shock, even when fluid intake is normal. We want to assess the patient for factors that can lead to shock. Areas to examine are poor clotting and hemorrhage, including the gums, wounds, and sites of dressings, drains, and vascular access. Also check under the patient for blood. Observe for any swelling or skin discoloration that may indicate an internal hemorrhage. Most signs and symptoms of hypovolemic shock are caused by the changes resulting from a compensatory effect. Shock may first be evident as changes in cardiovascular function. As shock progresses, changes to other body systems becomes evident, such as changes in the respiratory, integumentary, renal, and central nervous systems. Ensure that vital sign measurements are accurate and monitor for trends indicating shock. A trend is indicated when all or any or all of the vital signs or other assessment findings move in a downward or upward direction over a period of 1 to 4 hours. Cardiovascular changes that occur with hypovolemic shock start with decrease in mean arterial pressure, leading to a compensatory response. We want to assess the central and peripheral pulses for rate and quality. In the compensatory stage of shock, the pulse rate increases above the patient's baseline to keep the cardiac output and MAP in normal levels, even though the actual stroke volume, the amount of blood pumped out from the heart per beat, is decreased. Increased heart rate is often the first sign of shock. Because stroke volume is decreased, the peripheral pulses are difficult to palpate and easily blocked. As shock progresses, peripheral pulses may not be palpable and a Doppler may be needed. For hypovolemic shock laboratory assessments, we see a decrease in pH, decrease in PaO2, increase in PaCO2, increase in lactic acid, increase or decrease hematocrit and hemoglobin, and an increase in the potassium. With vasoconstriction, diastolic pressure increases, but systolic pressure remains the same. As a result, the difference between the systolic and diastolic pressure, or the pulse pressure, is smaller or narrower. Monitor blood pressure for changes from baseline levels and for changes from the previous measurement. For accuracy, use the same equipment on the same extremity. We want to validate an abnormal electric blood pressure reading with a manual blood pressure reading. Systolic pressure decreases as shock progresses and cardiac output decreases. A reduced systolic pressure narrows the pulse pressure even further. When shock continues and interventions are not adequate, compensatory mechanisms fail. Both systemic and diastolic pressures decrease, and blood pressure is difficult to hear. Palpation or a Doppler device may be needed to detect the systolic blood pressure. Oxygen saturation is assessed through pulse oximetry. Any values below 70% is considered a life-threatening emergency. Respiratory changes with shock are an adaptive response to help maintain gas exchange when tissue perfusion is decreased. Assess the rate and depth of respirations. The respiratory rate increasing during the shock is to ensure the oxygen intake is increased so that it can be delivered to critical tissues. Kidney and urinary changes occur with shock to compensate for decreased mean arterial pressure by saving body water through decreased filtration and increased sensitive indicators of early shock. We want to measure urine output at least every hour. In severe shock, urine output may be absent. When hypoxia or anoxia persists beyond that of an hour, patients are at risk for an acute kidney injury or kidney failure. Skin changes occur because the reduced blood flow in the skin, an early compensatory mechanism in skin blood vessel constriction, which reduces skin perfusion. This allows more blood to perfuse the vital organs, which cannot tolerate low oxygen levels. We want to assess the skin for temperature, color, and moisture and elasticity. With hypovolemic shock, the skin feels cool or cold to the touch and is moist, whereas the mucous membranes are dry. Color changes appear first in the oral mucous membrane and in the skin around the mouth. In patients with dark skin tones, pallor or cyanosis is best assessed in the oral mucous membrane. Other color changes are noted first in the skin of the extremities and then in the central trunk area. The skin feels clammy or moist to the touch, not because sweating increases, but because the normal fluid loss through the skin does not evaporate well on cold skin. And shock progresses, skin becomes mottled, and skin elasticity is decreased. Patients with light skin tone have an overall grayish blue color, and patients with darker skin appear to have an underlying reddish glow. In older adult patients, skin turgor is an unreliable indicator for hypovolemia due to the decrease in skin elasticity. We want to evaluate capillary refill time by pressing on the patient's fingernail until it blanches, and then observing how fast the nail bed resumes color when the pressure is released. Normally, capillary refill color resumes as soon as the pressure is released. With shock, capillary refill is slow or may be absent. Capillary refill is not a reliable indicator of peripheral blood flow in older adults who have anemia, diabetes, or peripheral vascular disease. The central nervous system changes with shock first manifest as thirst. Thirst is caused by stimulation of the thirst center in the brain in response to decreased blood volume. We want to assess the patient's level of consciousness and orientation, which are sensitive to cerebral hypoxia. In the compensatory stage, patients may be restless or agitated and may be anxious or have a feeling of impending doom. As hypoxia progresses, confusion and lethargy occur, which progresses to loss of consciousness or cerebral hypoxia worsening. Skeletal muscle changes during shock include weakness and pain in response to tissue hypoxia and anaerobic metabolism, which are later indications. Weakness is generalized and has no specific pattern, and deep tendon reflexes are decreased or absent. Interventions for patients in hypovolemic shock focus on reversing the shock, restoring fluid volume to normal range, and preventing complications. Monitoring is critical to determine whether the patient is responding to therapy or whether shock is progressing and a change in intervention is needed. Surgery may be needed to correct some causes of shock. The purpose of shock management are to maintain perfusion, increase vascular volume, and support compensatory mechanisms. Oxygen therapy, fluid volume replacement, and drug therapy are useful. Oxygen therapy is used at any stage of shock and is delivered by mask, hood, nasal cannula, endotracheal tube, or tracheotomy tube. Maintaining O2 saturations at 90 to 96 is our goal. Supplemental oxygen with normal oxygen saturations is no longer recommended because it may be associated with increased mortality risk. IV therapy for fluid resuscitation is the primary intervention for hypovolemic shock. However, the type and amount of solution remains a subject of debate. Accordingly, the type of solution that is used generally is crystalloid, and colloids are often used for volume replacement. Crystalloid solutions contain non-protein substances such as minerals, salts, and sugars, and colloid solutions contain large molecules of proteins and starches. Crystalloid fluids help maintain an adequate fluid and electrolyte balance. Two common solutions are normal saline and lactated ringers. Normal saline, or 0.9% sodium chloride in water, is a replacement solution used to increase plasma volume and can be infused with any blood product. Ringer's lactate is considered a balanced salt solution containing sodium chloride, calcium, potassium, and lactate. Those isotonic solutions expand volume, and the lactate buffers acidosis. Selection of specific fluid is based on the patient's fluid and electrolyte status, acid-base status, and organ function. Action alerts: we use only normal saline for infusion with blood or blood products because the calcium in lactated ringers induces clots from the infusing blood. Protein-containing colloids fluids help restore osmotic pressures and fluid volumes. Blood products are used when shock is caused by blood loss. These fluids must also include packed red blood cells, platelets, and fresh frozen plasma. Packed red blood cells increase hematocrit and hemoglobin levels along with some fluid volume. Drug therapy is used in addition to fluid therapy when the volume loss is severe and the patient does not respond sufficiently to fluid replacement and blood products. Drugs for shock increase mean arterial pressure, venous return, and cardiac output, resulting in improved perfusion. In the emergent state, we have to ensure a patient's airway, insert an IV catheter, maintain or established catheter. A large bore catheter is suggested. If an IV catheter cannot be obtained, a central venous catheter should be considered. Correct hypoxemia by administering oxygen to maintain oxygen saturation to 90 to 96. Supplemental oxygenation, again, is no longer recommended if the saturation is normal. We want to elevate the patient's feet, keeping the head flat, or elevate at no more than 30-degree angle. We want to examine the patient for overt bleeding. If overt bleeding is present, apply direct pressure to the site. Administer drugs as prescribed. Do not leave the patient. And when going home, educate the patient and family on early signs of shock. The expected outcome is that the patient's vascular volume will be restored with normal tissue perfusion. Sepsis is an extreme response to infection that can cause tissue damage, organ failure, and death if not treated promptly and appropriately. Septic shock is a subset of sepsis that is associated with a much higher risk of death than sepsis alone. Septic shock is associated with both systemic inflammatory response syndrome, or SIRS, and multiple organ dysfunction syndrome, or MODS. No single test confirms or rules out shock. Changes in laboratory data may support the diagnosis. As shock progresses, increased anaerobic metabolism results in lactic acidosis, and arterial blood gases values become abnormal. The pH decreases, and partial pressure of arterial oxygenation, or the PaO2, decreases, and the partial pressure of arterial carbon dioxide, or the PaCO2, increases. Other laboratory changes occur with specific causes of hypovolemic shock. Hematocrit and hemoglobin levels decrease if shock is caused by hemorrhage with poor clotting or large open wounds. When shock is caused by dehydration or a fluid shift, hematocrit and hemoglobin levels are elevated due to hemoconcentration. When infection is confined to a local area, it should not lead to sepsis and shock. In the adult whose immunity and inflammatory responses are effective, the presence of organism invasion first starts as a helpful local response of inflammation to confine and eliminate the organism and prevent the infection from becoming worse or widespread. The white blood cells in the area of invasion secrete cytokines to trigger local inflammation and bring more white blood cells to kill the invading organism. The results of this response constrict the small veins and dilate the arterioles in the area, which increase perfusion to local infected tissue. Capillary leak occurs, allowing plasma to leak into the tissues. This response causes swelling or edema. The duration of inflammation depends on the size and severity of the infection, but usually it subsides within a few days when the infection has been managed by these responses. A benefit of inflammation is that it is limited only to the area of infection and stops as soon as it is no longer needed. The patient does not have a fever, tachycardia, decreased oxygen saturation, or reduced urine output. Sepsis and septic shock are medical emergencies. Both conditions remain a major cause of mortality and morbidity and are the most expensive healthcare problem in the United States. In 2016, the third international consequences definition for shock and septic shock were introduced. Sepsis 3 is defined as sepsis as the life-threatening organ dysfunction brought on by a dysregulated response to infection, and septic shock is a term used to describe a subset of sepsis in which circulatory, cellular, and metabolic abnormalities substantially increase the risk of death over the association with sepsis alone. According to the Center for Disease Control and Prevention, each year 1 in 3 patients who die in the hospital have sepsis. Sepsis affects more than 1.7 million adults annually and is the cause of death of nearly 270,000 Americans per year. Patients especially at risk for sepsis are those who have any type of reduced immunity and those who have a central line. Central lines in place, even for short periods, create a potential direct access point for microorganisms and can lead to central line-associated bloodstream infections, or eclampsia. Prevention is the best management strategy for sepsis and septic shock. We want to evaluate all patients for their risk of sepsis, especially in older adults, because the risk of sepsis-related disease increases with age. We want to use aseptic technique during invasive procedures and when working with non-intact skin and mucosal membranes in patients. We want to remove indwelling urinary catheters and IV access lines as soon as they are no longer needed. We want to ensure that the patient receiving mechanical ventilations are weaned from ventilator as soon as possible. Because sepsis can be a complication of many conditions found in an acute care setting, always consider its possibility. Early detection of sepsis before progression to septic shock is a major nursing responsibility. The nurse is the healthcare provider professional most in contact with the patient and is in a unique position to be able to detect subtle changes in appearance and behavior that are indicative of sepsis. Scores can be calculated by the nurse, or many of these screening tools, such as the Muse, have been used in the integrated healthcare system, electronic records to aid in prompt recognition and treatment of sepsis. When using appropriately, the Muse can reduce the number of codes in the hospital setting as much as 50%. The screening tools combined with the astute nursing assessment lead to early detection, which can significantly alter the progress or prognosis for a patient with severe or septic shock. Early detection can also be made by the patients and the family. This is especially important for patients who are discharged to home after an invasive procedure or surgery. We want to teach patients and families the signs and symptoms of local infection, so that local redness, hyperpigmentation, pain, swelling, purulent drainage, and loss of function, and early sepsis, which is fever, urine output less than intake, and lightheadedness. We want to teach them how to use a thermometer and to take the temperature twice a day and whenever they are not feeling well. We want to urge those with symptoms of early sepsis to immediately contact their healthcare provider. And we want to teach them that if antibiotics are present, they should take these drugs as prescribed and should complete the entire course. Age is important because sepsis develops more easily in older patients. Ask about the patient's medical history, including recent illness, trauma, invasive procedures, or chronic conditions that may lead to shock. Want to check with the drugs that the patient has used in the past week. Some drugs may directly cause changes leading to shock. A drug regimen may also indicate a disorder or problem that can contribute to sepsis. A regimen that includes aspirin, corticosteroids, antibiotics, or cancer medications. The signs and symptoms of sepsis and septic shock occur over many hours, and some changes during the progression. Some signs and symptoms of sepsis are nonspecific and present similarly to other conditions such as pancreatitis or acute respiratory failure. Cardiovascular changes differ in the progression of sepsis and septic shock. During the compensatory stage, cardiac output is normal to be elevated as are heart rate and blood pressure, although this is an indication of a worsening condition rather than an improvement. Increased cardiac output is reflected by tachycardia, increased stroke volume, a normal or slightly elevated systolic blood pressure, and elevated diastolic pressure. Pulse pressure may also be increased initially. Increased cardiac output and vasodilation make the skin color appear normal with pink mucosal membrane, and the skin is warm to the touch, or hyperdynamic state. This situation is temporary, and eventually the cardiac output is greatly reduced, hypodynamic state, as evidenced by cool, mottled extremities, thready weak pulses, and delayed capillary refill. With progression, DIC, or disseminated intravascular coagulation, occurs as a result of excessive clotting, which formation of thousands of small clots into the tiny capillaries of the liver, kidney, brain, spleen, and heart. DIC reduces perfusion and gas exchange, and it decreases oxygen saturation, causing widespread hypoxia and ischemia. The huge number of small clots uses clotting factor and fibrogen faster than they can be produced, which eventually leads to poor clotting. This leads to hemorrhage, which occurs in septic shock. Coupled with continued capillary leaking, bleeding caused by hypovolemia, and dramatic decrease in cardiac output, blood pressure, and pulse pressures, the signs and symptoms of this phase are the same as those in the later stages of hypovolemic shock. Respiratory changes are first caused by compensatory mechanisms that try to maintain oxygen with a rate increase. The lungs are susceptible to damage, and the complication of acute respiratory distress syndrome, or ARDS, may occur in septic shock. ARDS is septic shock is caused by the continued systemic inflammatory response syndrome, increasing the formation of oxygen-free radicals, which damage lung cells. ARDS is in a patient with septic shock has a high mortality rate. Skin changes differ as sepsis progresses. In the hyperdynamic state, the skin is warm and no cyanosis is evident. With progression to septic shock, the skin becomes compromised from lack of circulation. It becomes cool and clammy with a paler ash-gray appearance, modeling in cyanosis. In DIC, you might actually see petechiae and ecchymosis that can occur anywhere. Blood may ooze from the gums, other mucous membranes, and venipuncture sites and around IV catheters. A kidney urinary change of low urine output compared with fluid intake indicates shock. When a patient who has known kidney problems suddenly starts to have low urine output, or be suspicious of sepsis or septic shock. Reduced output is caused by low circulating volume and hormonal changes. Kidney function decreases and serum creatinine levels rise. As septic shock progresses, it can lead to multi-organ dysfunction syndrome, or MODS. MODS is defined by progressive organ dysfunction in two or more separate organ systems requiring medical intervention to remain homeostasis. MODS is a severe complication of both infections, bacteremia, pneumonia, and non-infectious major trauma conditions. The severity of MODS varies from mild impairment to irreversible failure. It is associated with significant mortality and morbidity. An indication that patients may be progressing in sepsis is often a change in their effector behavior. When I compare the patient's current behavior, verbal responses, and general effect with those assessed earlier in the day or the day before, this may seem just slightly different in their responses and greeting, comments, or jokes. They may be less patient than usual or act restless or fidgety. Patients may make statements such as, "I feel as if something is wrong, but I don't know what." If behavior is changed from prior assessment, consider the possibility of progressing shock or sepsis. The priority collaborative problems for patients with sepsis and septic shock are widespread infection due to altered immunity, potential for organ dysfunction due to inappropriate clotting, poor perfusion, poor gas exchange from widespread infection. So now that we've learned about sepsis and septic shock, we're going to talk about how to take action. We're going to divide that into a 1-hour bundle, a 3-hour bundle, and a 6-hour bundle. For the 1-hour bundle, once we've determined my patient has sepsis, we're going to measure a lactic level. We're going to obtain blood cultures before administering our antibiotics. Then we're going to administer the antibiotics, broad spectrum. We're going to begin a rapid administration of 30 milliliters per kilogram of a crystalloid for hypotension or a lactate of greater than 4. We're going to apply vasopressin if hypotension continues during or after fluid resuscitation to maintain a mean arterial blood pressure map of greater than 65. For that 3-hour bundle, we are going to be seeing that the 3 clinical criteria are met, and that would be we're seeing that the patient has some 2 or more SIRS organ dysfunctions. During that 3-hour bundle, we're going to make sure to measure that lactic level again. We're going to make sure that that fluid resuscitation is occurring and making sure that if it is occurring that we're having some relief from the hypotension, or we are adding that vasopressin to assist with keeping those blood pressures up. In the 6-hour bundle, we are doing a reassessment of the volume status and tissue perfusion, vasopressor administration, repeat a lactic measurement. We're going to document the time 0, interventions, our reassessment, and how we approach that. We're going to use a team approach, and we're going to talk about how our patient's doing and whether or not this patient is going to need more interventions. Slide is just a really great slide and kind of breaks down how we do our health promotion for disease prevention, our chronic disease care, hospice and palliative care, and then regenerative or restorative care. This is for home care management and self-management education. The last step is to evaluate the care of the patient with sepsis or septic shock. The expected outcome of the patient will be to maintain that aerobic cellular metabolism.